I'm James Hyder. I'm a patient advocate with Lung Cancer Foundation of America, here with Dr. Jacob Kaufman. Welcome.
Thank you so much for having me. I'm Jacob Kaufman. I'm a assistant professor in thoracic medical oncology, so a lung cancer specialist at the OSU James Comprehensive Cancer Center, and a physician scientist who does research in lung cancer.
It's been awesome getting to know you better and learning your work. Can you tell me a little bit about what a patient ought to ask a doctor about biomarkers?
So let me tell you about kind of how I think about, or what a biomarker is. So really when we use the term biomarker, it's kind of shorthand for clinically actionable biomarker. So a biomarker could include a bunch of other things, but the ones that we really care about, clinically actionable means it helps your doctor make clinical decisions about how to tailor the treatment for your cancer to you and your cancer specifically. And in really over the last 20 years, understanding which biomarkers a given lung cancer patient has been critical to both getting them to the best possible standard therapies as well as a range of clinical trials.
Gotcha. So I'm starting to get that having your biomarker, knowing what it is really important. Can you just speak a little bit more to that?
Yeah, so and the whole every year there's probably going to be some additional biomarkers, so things that are kind of in the emerging biomarker category where maybe they're not being used to make decisions now, but we think that they could be. Let me start with sort of a different type of biomarker and then transition to what most people think about when you're talking about like patient groups and support groups in terms of a targetable biomarker. So there's another category where knowing the PD-L1 status or knowing the tumor mutational burden or knowing the MSI status, those are three biomarkers that are important for kind of understanding how much benefit there's going to be from immune therapy. But I think for the purpose of this conversation, most patients, when they're thinking about what's my biomarker, they're thinking about mutations that happen in the early evolution of the cancer, where the mutation really drives the progression of the cancer. And for some of these, EGFR, ALK, ROS, RET, KRAS, BRAF, and some others, there are, in many cases, oral therapies. In most of those cases, we're talking about oral treatments where the drug is not killing every cell, not killing every cancer cell, but only a cancer cells that has that mutation biomarker. That's what it's like, a key and a lock sort of thing, where the mutation, the drug only works if it fits into the part of the protein that's the mutation.
So it sounds like not all lung cancer is exactly the same. It's like a whole bunch of different things.
Thank you for saying that. That's a really great way to put it. Every patient's lung cancer is different from every other patient's. But by understanding the biomarkers, we can help get the best treatment, the most effective treatment delivered to the patient who's most likely to respond.
That makes so much sense. So I'm sure a lot of people would be wondering, is biomarker testing covered by insurance?
So biomarker testing is an essential component for non-small cell lung cancer. And your oncologist you should ask these questions to your oncologist, and they will tell you if biomarker testing is right for your cancer. And it almost always is, although there's sometimes very small cancers where there's not any proven way to act. But even then, even then, most of the time insurance will cover. But in the later stages, where it's patients that are undergoing radiation, or where the cancer may have already spread out of the lungs, a stage 4 case, those are all in guidelines, and insurance companies should be covering all of that testing.
Right. So can you speak a little bit about what's coming up as it relates to biomarkers and maybe the treatments, the advancements that are on the horizon?
Each of the biomarkers kind of gets its own class of drugs that are effective only for the patients that have those biomarkers. And one really cool thing is that that first discovery of a drug that inhibits or that benefits a certain class of patients, that's like a home run. But then it's like the guy that hit the home run hit it just over the fence, and then the next drug that comes up is maybe Ted Williams, and you're getting a drug that hits the same target but hits it harder and better. So every, not necessarily every year, but often the way it will go is the biomarker gets discovered, the first set of drugs gets discovered, and then the second generation of drugs is a little better, and the third generation of drugs is maybe a lot better. And so clinical trials that are testing how we can keep raising the bar for all of these biomarker groups happens every year, and is a really exciting way to kind of look forward to the future, where we're building on our successes and getting better at treating lung cancer every year.
I mean, as a guy who has lung cancer, it gives me a lot of hope to think about all the developments that are coming. Is there anything else that you want to add about biomarkers in lung cancer?
Yeah, so I think most of the time what we're thinking about is these one-to-one pairs where you've got a mutation in a gene and you have a drug that's specifically targeted to that mutation. But one thing that I'm excited about in the future is some more different sorts of biomarkers, things that could be used, for instance, to predict which patients are going to respond to immune therapy, or to tailor their immune therapy. So maybe there's a dozen different possible combinations that could be tested over the next 5 years. The mutation biomarkers may be part of the story, but there are ways that we can test things about a patient's immune system and how it's interacting with the cancer, or about resistance mechanisms that are going on in the cancer. And understanding those types of biomarkers may actually be critical to kind of the next set of clinical trials. And again, the goal of all of these biomarkers is to take a patient and understand what treatment is going to be most effective for their specific cancer.
Can you talk a little bit about some of the things that can make immunotherapy more or less effective?
Yeah, so first let me kind of talk a little bit about what immunotherapy is. So in chemotherapy, we're giving basically toxic compounds that are trying to poison the cancer cells. In targeted therapy, we're using inhibitors that are blocking these biomarker-directed mutations. So you're giving an oral therapy that's going in and blocking the effects of a mutation, and by depriving the cancer of those pro-cancer effects, the growth factor signals from the mutation, that's killing the cancer cells. Immune therapy helps a patient's body, helps a patient's immune system do a better job of recognizing and attacking cancer cells. And most of the immune therapies that are approved for use now involve sort of taking away a camouflage or an inhibitory signal that's helping the cancer cells hide from or evade the immune system. And when this approach works, a patient can actually be, in a best case scenario, can become immune to their own tumor. And in some cases, we actually do think that there are some patients with stage 4, even lung cancer, that have at least the potential of being cured with immune therapy approaches. But it doesn't work for everybody. And we do have some biomarkers that help us predict which patients are more likely to respond or less likely to respond, but it's not a one-for-one match. So PD-L1 is a biomarker, and in lung cancer, we're assessing the percentage of cancer cells that under the microscope are expressing positive levels of this PD-L1 protein. And PD-L1 and PD-1, they're the actual targets of one of the more common classes of immune therapy drugs. And what they do to help they help the cancer evade the immune system. When the T cells come in and try to attack the cancer cells, the PD-L1 is the signal that tells the immune system to leave the cancer cells alone.
So the PD-L1 is kind of, the higher that number, it's kind of the more camouflage is on the cancer.
Exactly. Okay. And it correlates with how likely a cancer is to respond to immune therapy.
So I certainly have known lots of people who are on an immunotherapy or a targeted therapy that eventually stopped working for them. So can you talk a little bit about what would cause resistance to some of these awesome drugs that are being developed?
Resistance can happen at the get-go. So there can be some cancers that just never respond to immune therapy, and then there's other cancers that can have a period where they're responding well, and then over time the cancer may become resistant. And every patient and every cancer kind of has its own different way that this plays out. So one possibility is, let's say there's a patient with 20 different areas of cancer in the body, and all 20 of them respond nicely to the immune therapy, but then 2-3 years later, one of them starts growing again. And so, we tailor our treatment decisions based on what we're seeing, and it gets very individualized. In that example I just gave, you might say, hey, the immune therapy is still actually working pretty well. We're just going to zap that one spot with some radiation and keep it going. But then there's other cases where, maybe it's a more widespread phenomenon, and maybe it's time to change to a different form of treatment or consider clinical trials. And sometimes we can track down exactly what changed in the cancer that caused it to be resistant. So there can be mutations that change the biology of the cancer.
So it sounds like at the time of a recurrence, that it would be maybe not always possible, but very helpful if a biopsy, or you can get to figure out exactly if there's something new happening in the recurrence.
I would say that's a major goal of the field. So a major goal of the field would be to be able to understand how the resistance mechanism that popped up in one patient's cancer may be very different from the resistance mechanism that was at play in another.
As far as if somebody had progression today, and so a treatment stopped working for them, is it possible for those that have more than one treatment that you would just start a new treatment, and that would then have an effect on that person's cancer cells?
So the standard approaches, if immune therapy stops working, are to go to different forms of second-line chemotherapy. Okay. But if I'm seeing one of these patients in my clinic, I'm really looking for what types of clinical trials might be available that are testing new and exciting ways, and many times still in the same sort of theme of can we engage the immune system with some new approach, a combination, let's say, of 2 different immune therapy drugs, or an immune therapy drug plus a drug that's designed to overcome a particular type of resistance.
So combining 2 different things to get a better outcome.
So but to date, we have not had a study that has shown that they can do this better than chemotherapy. There's some that seem pretty equivalent to chemotherapy, but that's a bar that we really want to move, far past. We want that to be the low bar, and we want to start seeing successes where we're taking resistant cancers and making them respond better.
All right, very good. Well, I just want to say thanks again for your time. And again, if anybody that's watching this has questions, you can go to lcfamerica.org. Lots of good resources there. And again, thanks for all the work that you and your colleagues are doing.
Yeah, thank you for talking.